We're going to talk about pediatric TB management in children. And TB is the epidemic of this decade after COVID. So the guidelines keep on changing every year, and we need to really get updated about the guidelines. What's new that is happening, because there's so much research that is going on in pediatric TB that we need to be updated with the new drugs that come out, the new regimens that are being devised. So WHO comes out with a guideline almost every year, and the National Tuberculosis Elimination Program then updates, because I'm on the task force. We have regular meetings to update these guidelines. So I'm going to talk about management, a little bit of the guidelines, and a little bit of personal experience, how we treat. There's not much that I can cover in this talk because there's too much in the guidelines that one needs to cover. So I'm going to give you small aspects about it. Now, if you look at the epidemiology, 11% of people globally got TB. And children formed 11% of the population that got TB. So almost 11 lakh people become ill with TB, and 2 lakh people die of TB. So almost 20% of the children ultimately die of tuberculosis. And I was just talking to Dr. Anupama and Dr. Nasrat, and it's really sad to see the kind of TB that is coming to the hospitals there, that most of the patients come in such morbid conditions that we are hardly able to do anything for them. Now, I believe there's a lecture on diagnosis of TB, so I'm just going to have diagnosis of TB in a short manner. So, diagnosis of TB, we have a presumptive pediatric TB diagnosis. When we were students, we actually used to diagnose TB on the basis of cough, fever, contact with TB, MANTU positive, and we used to start treatment. That's how because we didn't have gene expert, we didn't have bacteriological diagnosis. So when you are talking about presumptive pediatric TB diagnosis, we look at certain features like fever going on, low-grade fever, evening rise of temperature, cough more than 2 weeks, the child is losing weight, and there may be a contact with a patient who's having TB in the house. There's failure to thrive or not putting on weight, or there's weight loss that is occurring. That brings out your antenna out, and we say, okay, there must be TB somewhere. Now, this is an algorithm. I don't know whether somebody is going to cover this, but I'm just going to take you brief into it. The same symptoms that I told you, is the mouse showing here? So on the top, you have these same symptoms: fever, cough, weight loss. You do a chest X-ray. If the chest X-ray is highly suggestive of TB, so you have miliary pattern, fibrocavitatory pattern, you have mediastinal nodes that are there on the chest X-ray, then you do straight away a CBNAT. That's your gene expert or TrueNAT. If your CBNAT is positive, you have a bacteriologically confirmed TB. You either treat as drug-sensitive TB or drug-resistant TB based on the rifampicin resistance pattern. So if you have rifampicin resistance, you treat it as DRTB. If you have rifampicin sensitive, you treat it with the first line. When your chest X-ray is not very specific, you give a course of antibiotics. And if these shadows persist, then you will do a NAT, CBNAT. Suppose your CBNAT was negative in the first instance, then you may consider doing CBNAT. Suppose you did a gastric lavage and you found it's not enough. You may consider doing a CBNAT with a BAL, because if you're highly suspicious, then you get a better specimen. So you may do a CBNAT with that. So you may try to get sample again, and you don't just say one report negative, that means it's negative. If you have a strong suspicion, repeat the test through a different specimen and then see the report. If it's positive, again the same pattern to do. If it's negative, then you may want to still treat as TB as clinically diagnosed probable TB. Okay, that would be your call based on your experience and the judgment that you've taken. If your chest X-ray is normal but these symptoms are there, then there may be extrapulmonary TB. Then you may want to look for lymph nodes. So you may look at cervical lymph nodes. You may want to do an ultrasound abdomen to look for lymph nodes in the abdomen. So you may look for other signs of extrapulmonary TB. Usually extrapulmonary TB, if you don't pick up on the chest X-ray, it's not going to be TBM. it's going to be abdominal lymph node TB or cervical lymph node TB. So you may do an ultrasound of the abdomen, or you may do ultrasound of the neck to make a diagnosis. So this is this is the algorithm that your NTP EP gives you. You have microbiological tests. Nowadays everybody insists that we need to have a microbiological test for TB. So you have your TB expert, so you have your gene expert. You have two types of gene expert. You have a normal gene expert, which is known as the RIF-MTB, in which you do your standard, which is through the program, which is free of cost for all your patients. And then you have a gene expert ultra. The ultra actually picks up less than 16 bacilli, so you have a better yield. So places where for CSF, the bacteriological load is less. Your gene expert may be negative. You may want to do an ultra in those patients. It's not available through the program. So remember, you can do expert through your program and not the ultra. You have a TrueNet, which is there in in Mumbai. Basically, we have gene expert. In Mumbai, we don't have TrueNet. But in a lot of district hospitals or rural hospitals, they have a TrueNet. It's an Indian-based molecular test that is there. Only thing is that it's not fully automated like a gene expert. If you all pediatric residents get time, go to the microbiology lab and see how gene expert is run. It's fully automated. You just put in the cartridge, you get the report in 2 hours. TrueNet, you will have to amplify it outside and then put it. So it's a little manual process, so it's not completely automated. Then you have these line probe assays, and these line probe assays actually are done for first line LP and second line LP. Both will look at NTB. First line to look for resistance to HNR, isoniazid and rifampicin. Second line LPA is for your fluoroquinolones and for your second line injectables. So if you got a gene expert which says RR, that's rifampicin resistance, you straight away go for a second line LPA to look whether it's a pre-XDR pattern or not. If you got RS, that means rifampicin sensitive, you will go to the first line LPA to look for isoniazid resistance, because even though rifampicin may be sensitive, 10 to 15% would still be resistance to isoniazid. So you will have to do an LPA in those patients. Now you have the expert that I was ultra. So ultra can detect up to 16 colony forming units. So that's why for extrapulmonary TB, where the bacteriological load is less, like say your bone TB, your CNS TB, your pleural fluids, you may want to do an ultra. Currently not in the program. It costs around 1,800. We do it at Wadia, but our yield, we have been doing a study where we've been comparing expert versus ultra, and we found that the yield is very, very good. The problem with ultra is that sometimes rifampicin resistance may be indeterminate. Why it happens? Because the yield is good, we get a low bacterial load. So in that low bacterial load, it can't pick up rifampicin resistance. So sometimes your ultra may give you an indeterminate report, and then it becomes difficult to interpret whether to start first line or to start second line. So most of the times we end up starting first line and then see the response to therapy. Otherwise we take a call about the second line later on. Now there is something which is in children we do gastric lavage, we do bronchoalveolar lavage. WHO also mentions nasopharyngeal aspirate, or it says stool gene expert. Stool gene expert would be wonderful because you don't need to do anything invasive in the child. You just pick up the stool and do it. The problem with the stool is that the way to concentrate the stool and to put the sample into the gene expert, there are various techniques and different methods, and it's quite tedious. So there's not one standardized method which is easy for the technician to do for the stool. So that's the reason why it's not come too much into place in India. We don't have data in India. We've started doing it at Wadia now, and we've found a technique which we find it easier to do. So we've started doing stool gene expert at Wadia, and if you look, there's one Bangladesh study from the subcontinent, and they found that sensitivity and specificity of ultra on stool was 58.6% and 88.1%. And expert had a sensitivity of only 37.9%. So it was more sensitive as compared to the regular expert. But we need data from India So we are comparing GL BAL versus the stool, and we are looking at the data, and it's quite promising. It's not that bad. So I think we can switch over from BAL and GL to just doing a stool test. Now, if you look at treatment of pediatric TB, rifampicin sensitive TB, when you look at the drugs, how are these drugs combination? How did we come to this combination? When we were residents, we used to give intensive phase of 4 drugs or sometimes even 3 drugs. So if we had non-severe TB, we used to use 3 drugs. And then the continuation phase was 2 drugs. It was only HNR. But with the increasing resistance, now we are onto a 4-drug regimen, irrespective of the kind of TB. Whether it's severe or non-severe TB, we give 4 drugs in the intensive phase and we give 2 drugs in the continuation phase. The reason why we use pyrazinamide in the intensive phase and not in the continuation phase is that pyrazinamide will actually work in an acidic medium. But when the bacteria are very rapidly growing, they produce a lot of acid. And that's the time when pyrazinamide works. So pyrazinamide will work in the intensive phase. It won't work in the continuation phase when there's no acid. So there's no point giving pyrazinamide in the continuation phase. INH and rifampicin, they basically work. Rifampicin works on the fast growers, INH on the slow growers. So that's the reason you continue INH rifampicin as your main tool. It's your main base of your AKT. And ethambutol is just added so that you prevent resistance to these drugs. So that's the thing that you talk about first line AKT. I thought this chart was very important for us to understand the kind of where these drugs are working. So if you look at mycolic acid, that's the cell wall, you have your main drug is isoniazid and ethionamide. So that works on the mycolic acid. You also have your delaminate that works here on the mycolic acid. Then you have drugs that work on the RNA synthesis, that's your rifa group, rifamycin group. Then the DNA guidase is your quinolones. Then something that works on the ribosomes are your linezolid, your aminoglycosides, and your clarithromycin. Your bedaquiline works on the ATPase synthesis. Ethambutol works on the cell wall. The inhibition of the folic acid synthesis is by PAS, and clofazimine works on membrane destabilization. So when you are devising a regimen, say for example even for antibiotics, when we devise a combination therapy, we always look at which combination will work on the ribosome, which is going to work on the RNA, which is going to work on the cell wall, which is going to be synergistic. So that's how we decide on a combination. Similarly, because of these different areas where it's working, you give a combination of antibiotics even in drug-resistant, drug-sensitive TB so that you have the drug working at different levels of the bacteria. Now, the standard therapy is 2 months of HRZE and 4 months of HRE. That's your standard therapy. Just remember, in case of neuro TB, spinal TB, you need to give continuation phase for 10 months. So it becomes 1 year therapy. You don't stop there. Okay? All kinds of pulmonary TB, drug-sensitive TB, all kinds of extrapulmonary TB, all kinds of clinically diagnosed TB, you are going to give this first-line therapy. And the dosing. Now, this is something which is evolving. When we were students, we used to use INH at 5 mg per kg and rifampicin at 10 mg per kg. Then there were a lot of studies that came out and which said that we need to increase the dose. So based on the pharmacokinetic data, now you have INH being given at 7 to 15, so we level it up to 10 mg per kg. Rifampicin at 15 mg per kg, pyrazinamide at 35, ethambutol at 20. Streptomycin we hardly use nowadays, but earlier when we were using 20. Important thing, remember the maximum doses. A lot of times we forget that. You have a 14-year-old who will come as 35 kilo. And then if you calculate that way, you will go more than the maximum dose. So don't go beyond the maximum dose. So rifampicin don't ever exceed more than 600, INH never more than 300. If you did rifampicin in a 35, INH in a 35 kilo, you would land up 10 mg per kg as 350 mg, which would be too high. So you stick to 300. Pyrazinamide to 2 grams, ethambutol 1.5 grams, and streptomycin 1 gram. So don't exceed the maximum doses. And you have FDCs that are available. All of you are using the FDCs in the clinic. It's difficult to remember this chart. So what we do is we keep this chart on our table. Everyone's table has this chart. So we look at the FDCs and we decide what is the combination we want to give. We either the pediatric and the adult. E is for the ethambutol. Your FDC pediatric contains H, R and Z. And E comes separate because it's not a dispersible tablet. So you get 100 milligram of E as separate. Whereas the adult tablet contains H, R, Z, E as a combination. Okay. So you can, depending on the weight bands, you use the pediatric ethambutol combination. And then once the child crosses 25 kilo, you will be adding the adult tablet in this thing. The problem with this, it's practically easy to say that you can use this. The problem with this, a child has to get up in the morning, say a 12 kilo child, he'll be taking 3 pediatric and then 3 ethambutol. Your pill burden is very high. The same medicine, if I prescribe from outside, I would be actually giving him probably 1 tablet in the morning and 1 tablet in the evening. So the pill burden becomes less. And a lot of children don't like to take this kind of thing. So what do? Tell them? We tell them dissolve the tablets in water. So your 3 tablets will get dissolved, it becomes into 1 syrup. Okay, so they take 1 syrup in the morning. And second, ethambutol, you can crush it, or if the child can swallow the 3 tablets, fine, otherwise crush it, all the 3 and give it with honey. So then the pill burden becomes less. So you have to be a little innovative in giving them the prescription. Because if they don't finish this 6 months therapy, you're going to be in trouble. Now, if you look at the new guidelines that have come out through WHO, which we still haven't implemented in the NTEP. One is there was a SHINE trial that was done in Africa and India, which came out with a recommendation is that for non-severe TB, please remember it's only for non-severe TB. What do you mean by non-severe TB? Isolated pleural effusion, just a single cervical lymph node. So you have a non-severe TB, primary complex. Then you use a combination of 2 months of HRZ. Some countries don't follow ethambutol as yet, so E is in bracket. And then you have 2HR with E. So you have only 4 months therapy. Now, when we discussed this in the meeting, I think all the experts were pretty skeptical about this. One, because this trial has been done in 2 centers in India. And though it's representative, our main concern was how will the medical officer pick up non-severe TB? Suppose he picks up a severe TB as non-severe and puts on this regimen, then what happens to the patient? So that is our main concern about the feasibility of identifying non-severe TB. How many people are actually going to pick up non-severe TB? So, and another thing, when I look at our data, we did a study on mediastinal lymph node TB. What we found is these mediastinal lymph nodes don't disappear in 6 months. When I talk about cure in mediastinal lymph node TB, I can't keep on doing repeated biopsies. So my cure is never proved in mediastinal TB. I would be going on treatment completion. So treatment completion would be on the basis of the radiological improvement. So what is my radiological improvement? Either they calcify or they disappear, the nodes. So if you keep on doing CT scans, which we do 6 monthly, or sometimes we do it at the end of 6 months and then after 3 months and then 3 months. What we found is either they calcify or disappear around 12 months. So it's not possible to stop treatment in them at 6 months. Forget 4 months, 6 months also it's not possible. Then you have these paradoxical reactions where you have patients whom you've started treatment, especially let's talk about TBMs. They don't have tuberculomas to begin with, and then while they are on therapy, they develop tuberculomas. So that's known as a paradoxical. It's like how you have IRIS in HIV, immune reconstitution. So it's because of your immune reconstitution, the body brings out a reaction. The child is improving, TB is improving, but there are new lesions that have come. So either they can come in the form of nodes. So you can suddenly get a child you're treating for pleural effusion and suddenly a cervical node comes up. So that's a paradoxical reaction. It doesn't mean treatment failure. And sometimes you may need to give steroids. Suppose you develop a tuberculoma, you may need to give steroids. Then how long do you give therapy in these paradoxical reactions? It's longer than 6 months, definitely. So you will have to individualize the therapy for the patient, what the patient requires. So I'm not sure we can go to 4-month regimen very soon unless all over the country we have medical officers who can pick up non-severe TB. So remember, guidelines are there to guide you, that every patient is an individual and you need to cater your therapy based on what that patient is having. Same for TBM. The WHO has now come out with new guidelines which says that instead of using ethambutol, you use ethionamide. So you use 6 months of H, R, Z and ethionamide. So you use 6 months of isoniazid, rifampicin, pyrazinamide and ethionamide instead of the standard regimen where we were giving 2 months of HRZE, 10 months of HRE. This is based on South African data where they have been using ethionamide. Ethionamide is a wonderful drug for CNS TB because it crosses the blood-brain barrier. The problem is we don't know what dose of H, R and Z and E we are supposed to use in CNS TB. A lot of trials are going on. Some of them say that H you may have to use almost 20 milligram per kg in CNS TB. R you may have to go up to 35 milligram per kg. So till we get this pharmacokinetic data to say what would be the ideal drug dosing for CNS TB, to go to 6 months therapy, you all have seen TBMs, you all see the follow-up, you see that they don't respond in 6 months. So again, till we don't get this pharmacokinetic data, we are not able to implement this recommendation for India as yet.
So what would be the continuation phase after this?
There's no continuation. It's a 6 months therapy of H, R, Z and ethionamide. There's no continuation phase. Now if you look at CNS tuberculomas, where we published this data, because when this came out, I was just going through what we had found the data. And when we look at CNS tuberculomas, we find that 12 months therapy is not enough. If you look at the data, again, how do you decide in tuberculomas whether the child is improved or not? You can't keep on doing biopsies. So we look at radiological recovery. And those who didn't have radiological recovery within 12 months, they actually needed treatment for 20 months. So you just can't stop it there. Similarly, those who had radiological recovery almost needed treatment for 14 months. So again, guideline is there to guide you, but each patient is an individual, as I told you.
So ma'am, how often do you go for MRScopy? What do you do?
We don't do spectroscopy, but we do an MRI pretty frequently. So I think once we start therapy, then depending on the clinical improvement, if the child improves, we may do it after 6 months. But if the child is not improving, I may do it earlier. Then once at 6 months and then once at 12 months to see whether there is no tuberculoma before I stop therapy. If at 12 months there is a tuberculoma sitting, then I would continue therapy and then do 3 to 6 monthly.
Is the repeat tick will come on?
I would not look at that is only to make a diagnosis of TB. I am coming to that kind of a case. So this is a child, 12-year-old. He came with headache, vomiting, 2 episodes of seizures. And he had received TB treatment in the past, one at 7 months of age for BCG adenitis, second at 7 years of age for cervical lymph node TB. There's no microbiological diagnosis. It was just a biopsy, granulomatous disease, and they started. And there was history of recurrent infections where salmonella was picked up. So this child was actually suspected to have a MSMD. He had 2 episodes of pneumonia. So a lot of immune problems in this child. Now this is the current CT that was done. And you can see there are a lot of these lesions. You can see this. You can see this. Okay. Now you have a child who is suspected MSMD. You feel this is recurrent TB. This child has. So on the basis of this, you would actually think this is TB. Now if you look at the CSF is okay. Proteins are 42, sugar is 64 cells, all lymphocytes. We did a multiplex PCR negative, gene expert ultra, MTB not detected, culture negative. We also did fungal workup negative. cysticercus negative, toxoplasma negative. So we didn't get a microbiological diagnosis of TB. MRI quite suspicious of TB, past histories of TB. So the standard would be to start this child on TB treatment. So you put it as clinically probable TB and you put the child on treatment. 1 month later the child has not improved. Finally we did biopsy of that lesion and this is what we found. This is nocardiosis. So you can see this filamentous AFP positive. So this is nocardiosis. So even though you have a clinically, so and here this child we did an MRS, there was lipid peak. So that made us start AKTing this child.
For which you have to have suspicion of nocardiosis, because if you directly do 20%, it will be negative.
Yes. But then we did 5% and 20% both. Because the problem was that the radiologist was very clear that this doesn't look like TB. So even though we thought this is TB, it didn't look like that. That's what made us go. Because we knew the risk of biopsy was 20%, there's going to be a chance that we are going to cause some damage. But we still went ahead and did the biopsy. And this is what we picked up.
That would be a stereotyping biopsy.
Yeah. Similar case, now I'll come to this. Now this child, 20-month-old boy from Nepal, fever, cough, weight loss for 2 months. Mantoux test positive, 14 millimeters. Gene expert negative. Aunt had pulmonary TB, was on AKT for 1.5 months. Her sputum was positive for AFP. So there's a contact, there's a history, there's Mantoux positive. So we started first line and he was started on first line by his doctor and then there was no improvement and then he was referred to us. So this is the X-ray, you can see this. There is mediastinal widening, there's a patch here, there's a cavity there. So everybody thought this is TB with the contact and all that. We did a BAL didn't pick up TB. So we did a CT guided biopsy of that lesion here. And what did we pick up? We picked this up on the biopsy. So you can see there's a cuticle and there is a body there. This was a lung fluke. Very classical TB. So here is a word of caution. When you start TB treatment on clinical basis, if there's no improvement in a month's time or so, get your anti-now. Probably you're dealing with something else. Okay? So don't wait. What happens most places, you start TB treatment, patient is lost to following up in the DOT center, and then the MO is continuing with the TB treatment. 6 months over, patient is said, treatment completed, not done an X-ray, not done a CT. What has happened to the patient, we don't know. So that's why I'm showing you these cases, that what happens. So I would still say you get a microbiological diagnosis in children. Now let's talk about adjunctive therapy of steroids. Okay, we use recommended steroids are only for few conditions: TBM, TB pericarditis, Addison's disease, Milleri TB, and TB uveitis. Okay. Prednisolone dose is 1 to 2 milligram or Dexa 0.6 milligram, so 0.15 milligram per kg per dose, 6 hourly for 2 to 4 weeks and then take over the next 4 weeks. That's the standard. Now there are instances where you may have to give steroids for a longer time, especially if you have tuberculosis or you have paradoxical reactions. Then you want to give steroids for a longer time at a dose that the child tolerates without causing side effects. So there have been instances where we give steroids for 6 months, 9 months. So it depends patient to patient. There are some places where you give steroids for even longer time or a higher dose of steroids. I have gone up to even 4 milligram per kg sometimes. So this patient, this is the kind of TB I'm seeing actually post-COVID. Drug-sensitive TB, but very severe form of TB. This child, 5-month-old, came with consolidations. CT had shown narrowing of the right bronchus, narrowing of the left mainstream bronchus, chest wall abscess, and obstructive emphysema of the right upper lobe. He was on ventilator for 72 hours. IV Dexa was given because he had this narrowing everywhere, and then oral steroids. He didn't improve with the standard dose of oral steroids. He went back on NIV. Then I had to give him 4 milligram per kg for 5 days and then taper to 2. How did we come to that? Because there was a past experience of using this. what we found, this was our study that we have done, that steroids, if you give rifampicin with steroids, you decrease the plasma level of steroids by 50%. So when you're giving 2 milligram per kg of steroid of prednisolone, and you use rifampicin, you are in fact giving only 1 milligram per kg. So there was one study, in fact my student had done this study on using steroids in different groups. So in TBMs we used 2 milligram per kg standard. One group had 4 milligram per kg for 1 month followed by tapering, and the third group had 4 milligram per kg for 1 week followed by 2 milligram per kg and then tapering. And we found that group that had 4 milligram per kg for 1 week followed by 2 had lesser tuberculosis, hydrocephalus as compared to the 2 milligram per kg, the standard thing. When we were giving 4 milligram per kg for 1 month, then the side effects were higher. So this was the reason why in this child we gave for 5 days. We could get the child off the NIV and then go back to this. But again you have to keep on monitoring the child. Sometimes again go back to 4, then come back to 2, then come back to 1. So it's not a standard protocol that I would be following here. Same thing for pyridoxine. When we were students, we were told not to give pyridoxine. But now there's enough literature which says because we are going to use INH at 10 milligram per kg, we are going to have a vitamin B6 deficiency. So you have to give pyridoxine at 10 milligram per day in drug sensitive. But if you're going to do drug resistant TB, you may have to give higher dose with cycloserine. So if you're going to use INH at 20 milligram per kg and cycloserine, you have to give pyridoxine at 50 milligram per kg. So remember that. Now if you come to drug resistant TB. Drug resistant TB, there are lots of classifications. You have monoresistant TB, where resistant to one drug. Isoniazid resistance is specifically mentioned separately, though it's monoresistant TB. Polyresistant is not HNR resistance, but any other 2 drugs resistance is known as polyresistant TB. Rifampicin resistance is on your gene expert, where you have not got your LPA or your drug sensitivity reports, and you have only picked up RR, where you consider it that with R, H is also resistance. Okay? Normally with R, H is usually resistant, and so you consider them as MDR or XDR. You don't consider them as only RRTB. Then you have MDR, where you have H and R both resistance. Pre-XDR, where you have HR plus fluoroquinolones. And then you have extensively drug resistance, where you have HR, quinolone, and your group A drug resistance. I'll come to the groups of drugs. So group A is either bedaquiline, denosumab, or both. So that is known as your XDR. Now these XDR patterns keep on changing, because initially we used to use injectables as first line in DRTB. So then it used to be injectables. Now we are using bedaquiline or linezolid as first line. So now these become your XDR pattern. So DRTB, again probable DRTB is when you have a risk factor, when you have close contact with an MDR, when you have close contact with a person who died on TB treatment, when you have a close contact with a person who failed TB treatment, when you have a non-response to first line. And I would say in a month's time you should decide that. You should not wait till 6 months to decide that. Or there was a person who had been previously treated with second line and now has got reinfected. Then you consider them to be probable MDR. Okay? And you have not been able to do cultures to prove that they are MDR. Now, how do you diagnose children with MDR? You need to do culture, DST, and you need to do NAT. On the basis of this, you diagnose as MDR. Now, this chart is also little difficult to follow, but I'll say all TB patients where you've done a NAT, okay, and you have you did a NAT and you found rifampicin resistance. So if you've got rifampicin resistance, you go on to the DRTB regimen. I'll come to that regimen. If rifampicin resistance is not detected, it's drug sensitive TB, start the treatment for drug resistant TB. Now you got your NAT positive, you have to do second line LPA of your fluoroquinolones and the injectables and start your regimen. If you got rifampicin sensitive, you have to do first line LPA for INH. And if your INH resistance is detected, you have to go on to the INH regimen, that is moxiflox, pyrazinamide, linezolid, clofazimine. I'm going to stop this chart here because I don't want to confuse you too much. But drug-resistant TB, what is the effective way of treating is you have various groups of drugs. So you have your group A, in which you have Levoflox, Moxiflox, Bedaquiline, Linezolid, Clofazimine. That's your group A. You try to use as many drugs from your group A as possible in your combination. Then group B, you have cycloserine. Group C, you have ethambutol, delanuminate, pyrazinamide, imipenem, meropenem, amikacin, ethionomide, PAS. So you try to make a 5-drug combination using group A and group B, and then if you require something from group C, ethambutol. In this order you will be using the drugs. So ethambutol, delaminate, pyrazinamide. So that's how you are going to use your combination. So the most important is 4 to 5 drugs from group A to and B. Do not ever add one drug to a failing regimen. And you need to monitor these patients for response to therapy. So you may be doing cultures pretty frequently, probably once in 3 months you'll be doing cultures. And you can use shorter or longer oral MDR regimens. I'll come to that. How do you do these regimens? So you have your MDR TB. You have got a pulmonary case. Age is 5 years and above. And you've done your second line LPA. You could use this 4 to 6 months of Levoflox, Clofazimine, pyrazinamide, ethambutol, then ethionomide, bedaquiline, and 5 months of Levoflox, Clofazimine, pyrazinamide, ethambutol. So you get this shorter regimen. I'll tell you, in Mumbai we are not able to use this. Why? Because in Mumbai Z doesn't work, E doesn't work, ethionomide doesn't work, Levoflox doesn't work. We have more of a pre-XDR pattern. So in Mumbai, we are not able to use this regimen. So most of the times, I think today was the first day I told one of my students that this patient we can use this regimen because she had only HNR. Other drugs were sensitive. But otherwise, you can't use this combination. In Mumbai, and right now, bedaquiline, though WHO has recommended in children less than 5 years, India has still not adopted this. DCGI approval has not come. So bedaquiline we are not able to use in children less than 5 years. So in them we actually start using the injectables. What we do in Wadia, we use them as compassionate grounds. So we still use bedaquiline and delaminate in children less than 5 years for compassionate use. So on that basis we avoid the injectables. So we take the approvals from the parents and then use these drugs. So you can use the shorter regimen in hardly any patient in India. In Mumbai, most of the patients will go on this longer regimen. Longer regimen is 18 to 20 months of Levoflox. I don't use Levoflox, I use Moxiflox because Levoflox most of the patients are resistant. Whereas high dose Moxiflox you can still use in these patients. So Moxiflox, bedaquiline you use for 6 months, not more than that. Sometimes I've used bedaquiline as an extension. So where I'm not able to use the other drugs, like what happens with linezolid is that most of them get peripheral neuropathy. So children are not able to tolerate 18 to 20 months of linezolid. So then it becomes a problem. How do you give a regimen after bedaquiline has been stopped? A lot of children get psychotic tendencies with cycloserine. So most of the times you will end up not completing the regimen with linezolid and cycloserine. So then how do you complete the regimen? So then sometimes I have asked for extensions of bedaquiline and delaminate. So I've used a lot of combinations of BDQ and DLM. Clofazimine, again, there is cosmetic problem. They have a lot of skin discoloration. They become red. So they all come back and say, school mein sab chidate hain ki red color ho gaya. And that color doesn't go. It remains. And there have been times when I have done scopies of these children and the whole intestine is red. So the discoloration is occurring not only of the skin, it's of the mucosa. And these children can sometimes land up with clofazimine-induced enteropathy. They can get severe diarrhea which doesn't stop. So you may start with this regimen, but you may not complete this regimen. You may go on to a very different regimen while you are on therapy. So these children require a lot of monitoring. And again, below 5 years to give BDQ, DLM combination, to give extension of these drugs. So these patients actually are very much individualized therapy. I'll be coming to one case that we discuss. So I told you about linezolid. Linezolid can cause lot of peripheral neuropathy. In fact, they come down to 300 milligram instead of 600 milligram. We usually use 10 milligram per kg. Lot of patients have actually started only with 300. I have not even gone up to 10 milligram per kg. When you do start patients on DRTB treatment, you have to do a pre-treatment evaluation which contains HIV, blood sugar, CBC, liver function test, TST, thyroid function test, urine routine, electrolytes. Because if you're going to start bedaquiline or delaminate, you need to have your QT in the normal range. So you need to have your sodium in the normal range, magnesium, calcium, albumin in the normal range. ECG has to be required. Now all this is done free of cost for all the patients. So even at Vadia we do it free of cost for all these patients. And these are the drug doses. I've already told you the first line. Now levoflox is 15 milligram, moxiflox 7.5 to 10, which is low dose. High dose is 15. Most of our patients go on to this high dose. Bedaquiline dose as per the weight bands is there. Delaminate is also per the weight bands. Cycloserine 15 milligram. Linezolid, we say 10. I'm telling you, we can't go higher. We have to go lower. Clofazimine 2 to 5 is too much. They'll end up with a lot of enteropathy, so you need to adjust the dose here. Ethironamide is 15. Aminoglycosides 200. So PAS is 200. I find PAS pretty good drug for children, though it's not there in the program higher on the best thing, but even South Africa found this drug to be excellent for children. So a lot of times I use a regimen which contains PAS, and it's not resistant in Mumbai. So again you individualize. Aminoglycosides we are hardly using. We use this as a salvage regimen, meropenem, imipenem as salvage. Now that doesn't come to the program to give meropenem. It's a costly affair. First is you put in a PICC line for meropenem, then give it for 6 months, 8 hourly. And meropenem, one vial would get over in this thing. So you will be using around 3,000 rupees per day regimen, just meropenem. So it becomes a very costly affair. Fortunately, we have donors who give. So they do give for this therapy. So I'll just discuss this case. 14-year-old female. She came with cough fever for 20 days in December 2020. She had a history of weight loss. She was pretty malnourished, BMI of 14. She had right upper zone fibrocavitary TB, and ESR was 32, and she was gene expert rifampicin resistance. LPA showed resistance to SLI, that is your second line injectable, no resistance to quinolones. And she was started on amikacin because she was only kanamycin resistance, not to amikacin. So she started on amikacin, clofazimine, cycloserine, linezolid, moxiflox. That was the era when we didn't have bedaquiline as yet. So she was on an injectable based regimen. Jan 2022, 13 months after starting therapy, her HRCT showed collapse consolidation with tiny calcific foci in the right upper lobe. So some improvement has started taking place. Bronchial technique changes in bilateral upper lobes, and then ESR 20, GL MJ culture was negative. So we thought she's improving to this therapy. What happened after this in May? This lesions worsened. Her culture became positive, and now she had become a pre-XDR pattern. So then when we went back, yes, there were compliance issues. They were throwing away the medicines. So I had to put her on a salvage regimen here. And this child went on BDQ, delaminate, linezolid, amikacin, meropenem, amoxicillin, clofazimine, cycloserine, PAS. Okay, this was my salvage regimen at that time. She also, after starting salvage regimen in August 2022, her MJ culture became negative. And her HRCT that showed now just right upper lobe involvement. All the other changes had become less. We did a BAL because I was not relying on the GL to tell me whether the culture is negative. So we did a BAL, culture became negative. But she continued to have this. So I did a VQ scan. VQ scan to check whether the medicines are reaching there or not. Because if there's no perfusion to that area of the lung, there's no medicine that is going to reach. So if you look at that, the upper zone, right upper zone, where the patch is, there's only 3.8% perfusion. That means no matter what I gave her, nothing would reach there. So just keeping on giving her medicines was not working. So she underwent a right upper lobectomy in December. We continued her AKT. By that time we removed her PICC line, we stopped the meropenem and all that. And now, when we send that lung tissue, there was no MTB on that. So now we are just going to finish her 24 months therapy and stop her therapy. So it's not standard, treatment for every patient. Every patient. There's a lot of other things. Vitamin D. We use a lot of vitamin D in TB because there are a lot of research on how vitamin D modulates. So we published this data of feasibility of salvage regimen using home-based IV meropenem with delamanid bedaquiline containing regimen in India. This is the first time in the world that people have done this in children, because people have done this in adults but nowhere in children. And all of them, all these patients, they became culture negative. So this was a very important lesson that all of us learned. Now this is standard NTEP guidelines with a little bit of individualization of every patient. There are other things in children where I won't be covering is BCG adenitis, paradoxical reactions, latent TB, extrapulmonary TB, especially your TBMs, TB and HIV. So it's quite vast. Just to say that we only talk about giving pyridoxine, but we don't talk about giving multivitamins. This was a patient who used to come to my clinic. And I gave everybody multivitamins, still they are on therapy. This child I stopped because she was tired of taking pills, so I stopped. She came back with Pellegra. And then I had to put her back on multivitamins, niacin, and then she improved. Now, this was a child who was being treated for cervical lymph node TB, and she was also on injectable based regimen. So I sent her to the ENT for getting a hearing screening done. And the ENT just happened to see the throat and he found a retropharyngeal swelling. So then he said there's something there. So then I got a CT and there was a retropharyngeal abscess. She was asymptomatic, but it was a huge abscess. So again I had to get an ENT to do an endoscopic drainage of this abscess, and not one time, 5 times. Because this child kept on filling up, kept on filling up, kept on filling up. This is paradoxical reaction. And if she is asymptomatic, I'm not going to give her steroids. It just needs to be drained off. So remember, paradoxical reactions can come in a very different kind of ways. So thank you very much. I hope you all enjoyed the talk.